I'll raise it up. So a good preparatory technique for the cervical spine is called cervical myofascial manipulation. Okay? So say you just have people who, even if they have instabilities, we already talked about if they have instabilities at certain segments, a segment below or above can be what? Hypomobile, right? That means if segments become hypomobile, there's likely going to be some hypomobile soft tissue as well. Typically, we have muscles that go into a guarded state, or muscles that go into a taut state, or muscles that may even go into a hyperactive state. You will hear these different words thrown around. And these muscles need to be down-regulated per se, all right? And so we're gonna actually have to do that with our hands, with implementing soft tissue techniques. So the goal is before we mobilize any joint, we want to actually make the soft tissues that are surrounding that joint extensible. Because what if those soft tissues surrounding that joint are taut? Are you going to be able to generate or perform the most effective joint mobilization technique? No, because you're going to have soft tissues still restricting that joint. So you want to address the soft tissue restrictions first, typically before addressing the joint mobilization restriction. All right, you got that? Because if there's some accessory motion restriction, likely there's going to be some soft tissue restrictions around that joint. All right, and that applies throughout the body. All right. So now, what am I going to do? Typically, I perform this technique with free up. All right, get a little free up. All right. This patient isn't allergic to free up. So look at my hand placement. I'm going to start right here. My hands are going to start just above the right upper trapezius. And I'm going to be lateral, just lateral to the paravertebral muscles. So with the cervical myofascial manipulation technique, I start right here just above the upper trap. My hands are capturing the paravertebral muscles. So I feel this finger right here is just along, just lateral to the spinous process. This hand right, this my ring finger is just lateral to the spinous processes. Starting from T1 and coming all the way up. You see how I'm working this? All the way up, like so. And then I get right here at the suboccipital, subcranial region, and I can add a little distraction. Normally this feels good to patients. How does this feel to you?
Good.
All right, good. It should feel good. And I can spend some time right here. And notice I have her positioned to where I can get to this, get to these paravertebral muscles on this side. Okay. Good. What is this technique called?
Cervical myofascial manipulation.
Yep. And so what are some paravertebral muscles we have back here? Look them up. Come around to this side over here. So notice I'm starting about right here. And longitudinal stroking. Longitudinal stroking. All the way up to subcranial spine. All right.
You said you're still applying that distraction force up there? Or no?
Yeah, so when I get here, I can apply a little distraction. Cup it right up under here. occipital protuberance, right? Then I can come like so. All right, another technique that you all have talked about. Suboccipital release. So come right here, you see this right here? My fingers are on her suboccipitals. What are those suboccipitals? So make sure you go back and review those suboccipital muscles. I'm gonna apply the pressure to the suboccipitals and just relax there. And what I want to feel the creep. I want to feel those suboccipital muscles relax, just sink into my fingers. That's what I'm waiting on. And when I feel that creep, that relaxation into my fingertips, I add a little bit more of cervical flexion, subcranial flexion, and cervical flexion. You see? Now, some may refer to this as inhibited distraction as well. So, some literature may refer to this technique as inhibited distraction as you add more flexion. Why is that? As I add more flexion, this technique becomes, can be termed inhibited distraction. Why is that?
Being distracted.
Okay, so the muscles are lengthening posteriorly of the posterior cervical spine. Those muscles are lengthening, but what is happening to the intervertebral foramen? They're separated. They're gapping. More space is being created. So, say someone has cervical radiculopathy. Could this be something that they could benefit from?
Yes.
Yeah.
So could you do this if they're contraindicated for like a traction, but you could do this instead? Is that what you're saying?
So, if they're contraindicated for a traction, what would make them contraindicated for a traction? Give me the condition.
Spinal cord injury.
So, if they have whiplash or trauma, this may be more safe than mechanical traction, because as the physical therapist, you can now grade it. Because as physical therapists, the difference between modalities, mechanical traction is in a sense a modality. So the difference between a modality and the use of our hands is that we are assessing as we are treating. Does that make sense? So everything that we do manually, we're not only treating, we're also assessing. That's why we're PTs, right? So in this case, if I have someone who's had whiplash and I think that they can benefit from this technique, I can't grade the mechanical manual traction because I'm not sensing anything with my hands. It's a machine doing the work. But if I'm doing the inhibited release technique, I could talk to the patient, I can get the patient response, I can grade what I'm doing, you see, and that will likely be a more effective treatment that will likely result in less adverse effects versus mechanical traction. Because if they come to me with a history of trauma for a motor vehicle accident and whiplash, me as the therapist, I'm not going to do mechanical traction. I'm not going to hook the patient up to a mechanical traction device, because now I cannot assess with my hands. I cannot grade and determine if I need to terminate. The only thing I know to terminate that treatment is if the patient says that, man, you need to stop this treatment. But what if the patient is afraid to say that, and the patient say, well, he put me on this mechanical traction, it's supposed to work, I just have to endure it if it's uncomfortable or if it causes any signs and symptoms. So I'm just gonna sit here and endure it. This 10 out of 10 excruciating pain because this therapist put me on here, and the therapist or the doctor is the all supreme and they know the best. You see? And now you got a patient doing something that they're likely not benefiting from and likely could be making things worse. But they're going to endure it just because you put them on there as the PT with the white coat on. You see? All right. So that's a technique. So GAs, I'm going to have you to write up on these techniques, and we're going to make slides on these techniques.
To add to that too, Bella, so this whole technique is trying to decrease guarding, right? So in an acute injury, whiplash injury, that guarding is protective and important, right? Until that patient has been stabilized, whatever is unstable that's a problem or has pressure on its problem, the body reacts by protecting and guarding to protect, right? And eventually, we know that those chronic whiplash patients, eventually that it doesn't need to happen anymore, but it's continued to happen, so it's going to be longer. So it may be an acute, somebody who has a fracture, obviously some of these people, maybe your modified short burst surgical hasn't been assessed, and they've determined that they're medically cleared for therapy. Maybe you don't do anything like this. But your patient who is still having burning after they shouldn't have burning anymore, and we're trying to increase motion, that's your patient you're doing this. Does that help?
Yes, ma'am.
Okay. Now, I'm just going to throw in one more technique because it's 11:38. We may not get a chance to practice them today, but the techniques that Dr. McClure and I infuse, we'll let you practice them on the next session, and then we'll keep infusing techniques because they're going to add up, fellas, and y'all can use them in the clinic. You can use them for assessment and also for treatment, okay? So now I'm just going to throw in one that could be a problem if someone has a forward head posture. You're going to see this a lot in the clinic, so you got to be prepared. So if someone has a forward head posture, the SCMs, sternocleidomastoid muscles, skull muscles, they're likely going to be taut. Why is that? They're bilateral flexors. So mid-cervical finus flex, they are going to be taut concentrically. They're more likely going to be weak eccentrically, right? So we want to work on the eccentric strength, then we have to work on the extensibility of these muscles. So a person is going to struggle with backwards bending of the cervical spine, and they're likely going to struggle with rotation as well, all right? Because if I have to rotate to the right, which sternocleidomastoid muscle has to elongate?
The left.
The right one, because remember the next is yes, left. Good job. Gotta know that, y'all. All right.
Also think about its effects. While it is a cervical flexor, remember cervical versus capital are different, right? So what at the craniovertebral junction, like an OA, what's happening to that tracks? Right, yes. So you got some cranial backward bending. So while we're getting cervical flexion, we're getting some cranial backward bending because of its attachment back here on the occiput. So it's the scum. We had an instructor, Dr. Pat, she calls it the scum instead of the SCM. Can't forget about the attachment on the occiput.
So look at this scum up. Look at this sternocleidomastoid muscle. Very unique. This muscle is like a sling muscle. Watch. Look at this muscle. So if I pull this muscle like this, what does it mimic? So think about a slingshot. If I pull it and say I let it go, boom, then there goes the rock. So I place a rock right here. So I place a rock right here, and I pull this thing as far as I can, and that rock should go, shoo. You see? So you can do muscle play of the sternocleidomastoid muscle. You should be able to grab it on most people. And if it's tight, it's gonna feel if it's taut, it's gonna feel hard. It may be feel fibrotic or very stiff. So you got to get that muscle, grab that muscle. This is sternocleidomastoid muscle play, and just try to get it into a sling position. You just grab the muscle belly, and you could work up and down this muscle. You see? Now, you try not. Does it feel like I'm pinching you? I'll just grab it.
It feels like you're about to choke me.
Okay. So now that's good observation that she said that. It can feel like you about to choke the person, because if you get in on that muscle, Just medial to this muscle is the deep cervical flexors. So one being your longest collar muscle. And you try to get in on that muscle, the patient can feel like they're choking. So you got to be very careful. Then you got to let the patient know, if you really want to get in and work on that muscle, you got to let the patient know how it's going to make them feel, so that they'll be aware of that. Yeah, it make them feel like gagging or choking. So it can be very uncomfortable. So let's see if I can grade this. How does that feel?
Oh, sorry, what?
Does this feel better?
Yes.
Okay, because I'm not as deep. Because I was grabbing it, so she gave me feedback. Because I was grabbing this muscle, but I was getting a little deep like this and getting into her deep cervical neck flexor. So I'm going to try to be a little bit more superficial with grasping that muscle. That's better?
Yeah.
There we go. So you get your patient feedback. So this is just lateral to medial mobilization of this muscle. Lateral to medial. Lateral to medial. You want to get as much lateral pull as you can. So I go to this side, and notice that I'm slightly side bending and slightly rotating to have access to the muscle. So to get access to the right sternocleidomastoid, I need this just slightly side bend to the left, slightly rotate to the left. All right, there we go. How's that feel?
That's fine.
All right, good. And so, sternocleidomastoid muscle play, or you may see manipulation. Now, what else can I do to the sternocleidomastoid? I'm gonna show you all something. I'm showing you a lot that you got to capture. So I can just strum and stroke it. I can come all the way up to the mastoid process and start from the sternum, the manubrium of the sternum, and come all the way up to the mastoid process. You see? Just strumming and stroking that sternocleidomastoid muscle. See, my GA is capturing this. Now, the sternocleidomastoid muscle, if it is taut, this is a very, very unique muscle. If this muscle is taut, it can cause headaches, it can cause vision problems, it can cause swallowing difficulties, it can cause, did I say hearing?
No.
Yeah, hearing problems. So this muscle can wreak havoc. It can also cause dizziness if it is taut. So if somebody comes in with cervicogenic dizziness, this muscle could be a culprit. You may want to assess this muscle, and if it's a problem, treat it. And so
when you got a patient who comes in with those complaints and you do your other special tests and they're clear, okay, your sharp cursor, all those instability tests, they're all clear, but those patients still have this, maybe you do some vestibular screens and that doesn't reproduce the symptoms, make sure you're looking at this.
Yes.
Myofascial trigger points, I've seen it. I had a classmate, we went to MF1, and she flew down and she was having this vestibular issues. And all of a sudden, man, we got her SCM. Whoa! And so the instructor treated her in class, and she was like 90 to 100% better.
So if this was causing, I don't know, like cervicogenic dizziness, would you do this in like max protection phase?
yes, I could do this in the max protection phase, because this is going to be preparatory work towards my supporting interventions. Because I gotta get my patient to moving better. So before I do anything, the soft tissue muscles and joint must have some mobility. You see, I can't produce any movement. I can't perform any therapeutic exercises or neuromuscular reeducation if the patient has no mobility. You see? All right, now, I want to stretch this muscle. How much time I got, GA?
It's 11:44.
All right, good. I got 6 minutes to maximize. Man, I got some good GAs. So now, I'm giving y'all a lot of techniques at once that my GA is gonna do a PowerPoint presentation on. and add it to the presentation so you all can practice these techniques. So now I say, okay, before I move on to my supporting interventions, I want to go ahead and stretch the sternocleidomastoid muscle. So say I want to stretch the right sternocleidomastoid muscle, all right? And we like to use the term SCM, right? That what Catherine Patler says, due to the attachment of the sternocleidomastoid with occipital.
Yeah, on the occiput.
On the occiput. On the occiput. So what I'm gonna do, now I'm gonna modify the technique so I don't be all in her face with this. I'm gonna bias her into some flexion. And I'm gonna maintain that flexion, right? And what I'm going to do is I'm stretching out the right side. I'm gonna side bend her to the left. And I'm gonna try to maintain this. Now, in the technique, what Patler does to maintain it is get the shoulder right here on the forehead to maintain that, and then rotate the patient to the right. Now, if you come in and look and you see this muscle is a sling muscle, you can see that when I side bend, flex, and rotate to the right, what is this muscle doing? It's lengthening, it's elongating. Very good job. And I can hold this now. You feel that stretch? Okay. And now I can back up off of that. Okay. So I can do that several times. Can I add muscle injury technique to that?
Sure.
Yeah, I can. So I can add a post-isometric relaxation to that. So I can bring it here, side bend here, rotate here. Now hold this position and don't let me move you. I'm gonna try to move her into left rotation. So this is an isometric contraction. Now relax. Now I can rotate her more to the right and maintain it. Notice I'm maintaining the flexion and I'm maintaining the side bending because of the attachments to the occiput.
Is there a reason you're flexing over extending? If it is a flexor, why aren't you doing the opposite?
So I'm flexing because of the attachment to the occiput. So that's gonna give it a greater stretch.
So it's kind of more of like a capital flexion almost, okay? So you're coming into some forward nodding, maybe a little bit of flexion. And then the other thing that he can do to increase it, right? So he's got a hold of the M and the O, but he could also take one hand down here and stabilize. What's the S and the C stand for?
Sternum.
Sure can.
What's the clavicle? Clavicle, right? So he could take a hand, the other hand, and he could stabilize with one hand and do what he just did with his shoulder in there, and he could stabilize the sternum and or the clavicle and separate the 2 points, right? But remember when it contracts bilaterally, it attaches back here, so it does this. So you got to come into the flexion in order to get full elongation.
Yes, ma'am.
So this is what this would look like. Do you feel a greater stretch?
There's kind of a sternal portion and there's a clavicular portion, and so depending on where you feel the tightness, you can stabilize and play around with it. You may find that part of it's tighter than the other part. So it's another tool in your toolbox.
Thank you.
But the flexion part is important.
Yes. Okay.
Okay. Any questions or concerns? So those are manual techniques that you all will have the opportunity. I don't want to throw too many in at one time, but you'll have an opportunity to practice those the next class period. All right, because this is going to be on your lab practical. Like I'm going to give you a scenario, or like how we've been doing, like what manual technique can you do to improve this? What joint mold technique can you do to improve this?
So just to have you guys thinking along that lines, what's a supporting intervention you could give that patient? You just worked on that because you found some restrictions. Now what would be a supporting intervention that you could do?
Self-stretching.
Self-stretching, what would you self-stretch?
You could do the towel.
Or the hand.
Yeah, you self-stretch the SCM, whatever tool you want to use, right? But just doing a following that up with a self-stretch, that would be one thing that you could do. Appropriate thing to do. And then what else? After you've stretched, what else do you want to improve?
Strength.
Strength. So what could you do with that?
Do the rotation.
So as we're going through this, you want to start thinking through this and think, how could you strengthen concentrically? How could you strengthen eccentrically? When would you want to do that? So just start having that thought process in your mind as we're going through these techniques. If you can start connecting that from the get-go, it'll really help you.
And then you think about a lot of this is National Physical Therapy Exam content. You can get asked a simple question, fellas, ladies and gentlemen, on a function of the SCM. Just simple as that, you know. But you have to know the muscle actions, you know. It all goes back to those foundation. So you gotta really review that gross anatomy, because now you see it come to play with manual therapy.
Yes, sir.
You know, and joint, soft tissue manipulation and joint manipulation. How much time I got, GA?
It's 11:50.
All right. Any questions? Any questions about anything? All right. We come back next week. We got